Very
good. Dr. Etesam, shall we start the webinar?
Sorry, Dr. Ayati, I lost the connections for a few minutes. We also are very pleased that we're here with you in the webinar, and I hope that this would be continued after and for the next webinars. And
of course,
it's an honor for us.
Oh, thank you. You're so kind.
Dr. Etesam, shall we start the webinar? We're saving the time at the moment.
Thank you, Dr. Arbabi. Yes, if you would like, you can start the webinar. Thank you.
Okay, thank you. Hello, everyone. I am Dr. Mohammad Arbabi. I'm a psychiatrist working in Tehran University of Medical Sciences and especially working in neuropsychiatric discipline. First of all, I would like to thank Dr. Etesam, the manager and the secretary of this webinar, that I think she arranged this webinar from 3 months ago. And I hope this webinar will be useful and interesting for all of the audience. In this webinar, other than me, Dr. Etesam, we have 3 other lecturers. Dr. Ayati joining us from US. He is working on geriatric medicine. And Dr. Vahabi from Roozbeh Hospital, and Professor Noroozian from Tehran University of Medical Sciences and Roozbeh Hospital as well. As you know, we are stuck in COVID-19 pandemics, and it seems that not end easily and soon. So in Appraise to Raise program suggested to have a webinar about the COVID-19 effects on brain and cognition. So we are going to present these subjects regarding this important issue. And I hope at the end of the webinar, we have a nice discussion about the updates of this issue. At the first step of this webinar, I'm gonna start to present my lecture as delirium in elderly patient admitted in hospital. Dr. Etesam, shall I start? Do you have any more comments in introduction of the webinar or not?
No, thank you. You can start. Thanks.
Thank you. Can you see my slides?
Yes, yes, we can see.
Okay, I selected the title Mind Delirium in patient with COVID-19 in the hospital for my talk, and I will explain more about this topic. First of all, I would like to share my disclosure and contribution to other pharmaceutical companies in Iran, and you can see here. But about this talk, I didn't have any conflict of interest with pharmaceutical companies. In this talk, about 30 minutes, I'm gonna talk about definition and etiology of the delirium, presentation and epidemiology in COVID-19 pandemics, especially. And at the third step, I'm going to talk about assessment and management of this condition in clinical practice. As you know, there is a significant change in definition of delirium in DSM-5 compared to DSM-4. In DSM-4, the core symptom of delirium is disturbance of consciousness. It means reduced clarity of awareness about the environment, and with some degrees of reduced ability to focus, sustain, and shift attention. As you see, the main symptom of delirium was disturbance of the consciousness. But in DSM-5, the definition changed to focusing on attention. In 2013, after changing this definition, the focus on consciousness was decreased, so the attention is the more important part of the definition of the delirium. It means that regarding this definition of the delirium, the condition is more wider than before. And we have lots of patients that maybe they have a good consciousness, level of consciousness, but because of impairment in attention, they are in delirium condition. Based on this definition, if we want to compare the situation with previous condition, we can see the same condition about the acuteness of the delirium. In 2013, in DSM-5 and in DSM-4, we have the same explanation about the course of delirium. In both of definitions, delirium is a short period that start acutely, and we can see changes in attention, awareness of the environment, and we may have some symptoms in memory and disorientation and language, fluency, and visual spatial ability. But there is a question: is delirium an acute condition or not? If we review evidence, we can find findings against the acuteness of delirium. There are lots of reports about the long time effects of delirium on cognition and ability of working well in patients following the delirium. You can see here the diagram that was published in 2018 in Lancet journal by Timothy Girard, that they showed after delirium, we can have up to 3 months or 1 year cognitive problems and disability. And in patients who had septic delirium or hypoxic delirium, the decline in the cognition and daily activity is more prominent. It means that we define delirium as an acute situation, although the sequences of symptoms and cycle of the delirium condition is very long lasting and it's not an acute. So we can conclude that following the COVID infections, if our patient suffer from delirium, it will not be as an acute situation, and it would be as a long-lasting and chronic condition. So, if we want to know about the rate of delirium in the hospital, there are lots of reports about this issue. But we did a study in Imam Khomeini Hospital 2 years ago, and we are at the moment publishing the report in journal, and we found that about 10% of our patients in Imam Khomeini Hospital are suffering from the delirium. It is different among different wards. For example, in surgery and in internal departments and emergency, the rate is different, but totally 10% of our patients suffer from delirium. And you know that the rate of delirium is different in different type of medical condition. The more severe medical condition, the more prevalent rate of delirium we can see. For instance, in dementia and stroke, the rate of delirium may be more prevalent than, for instance, in cardiac condition. But in cardiac surgery department, the rate of delirium is very high. It means that delirium could be as a result of metabolic and physiologic state of our body, and whenever the situation is more severe, the condition related to delirium is more severe to make the symptoms and disability due to their delirium state. Other than the severity of the symptom, if we want to mention the importance of delirium, we can point to burden of the delirium. When a person suffer from delirium, other than problems he or she experienced in the episode of delirium, there are some consequences that are so dangerous for the patient. For instance, following a delirium episode, patient may have increased risk of mortality up to 62%, and they may lose 13% of their active life in future. It means that the burden of delirium is high for patient and for any health system. Delirium is a secondary condition. Lots of factors are involving in making a patient delirious. There are some predisposing factors that are in the history of the patient and make patients vulnerable to delirium, and there are some precipitating factors. For example, predisposing factors are dementia, cognitive impairment, previous delirium history, functional impairment, for example, disability in walking, or visual impairment, hearing impairment, older age, all of them are predisposing factors. In these conditions and circumstances, there are some precipitating factors. If they add to predisposing factor, make delirium. For instance, if a patient have dementia or cognitive impairment or previous history of delirium, and they had a new infection, adding infection on this predisposing factor make a patient delirious. And the summation of these two factors are the main issue. For instance, if a weak predisposing factor like depression, adding to a strong precipitating factor like a major medical condition like hip fracture or a major orthopedic condition, the summation of these two factors is high and push the patient in delirious state. So important that we consider predisposing factor and precipitating factors as well. We did a study in Imam Khomeini Hospital, and among the precipitating factors, we found that lack of visual aid and anxiety are two main precipitating factors in patients who suffered from delirium in ICU. Regarding the anxiety, we didn't conclude that the anxiety is a prodromal symptom for delirium or precipitating factor. But I think it's important when we see some patient in general hospital, in ICU, in any other ward other than psychiatric ward, and they suffer from anxiety, we should consider delirium maybe come after. And the anxiety could be as a precipitating factor for patient with delirium. As you know, if you want to explain delirium, etiology, and neurophysiology, we usually mention about neurotransmitters like dopamine, like serotonin or norepinephrine and acetylcholine. Other than these neurotransmitters, recently we have lots of reports and explanations about the neuroinflammatory process in delirium. Following any major medical conditions, there is a cascade of cytokines that produce in our body and in circulating system, and they can go through the blood-brain barrier after the leaking this barrier, and they could affect our nervous system. And it is understandable that in COVID-19 situation, when a patient suffered from severe condition like pneumonia or like fever and an inflammatory reaction, the cascade of cytokines will be activated as other condition. And delirium could be as a possible condition following COVID-19 condition. So if we want to review the symptoms of COVID-19 infection, we have psychiatric symptoms as well other kind of medical symptoms. I reported here psychiatric symptoms in SARS and MERS that are two conditions resulting from coronavirus infection before COVID-19 situation. Studies show that patient may experience impaired concentration, impaired memory, confusion, emotional lability, and altered consciousness. All of these symptoms could be seen in delirium as well. It means that delirium symptoms and delirium condition was prevalent in coronavirus infection disease. So we did a study in Imam Khomeini Hospital, and we review all of the psychiatric consultation in last year. And among 132 consultations referred to our department, we found that the diagnosis of delirium is the most prevalent medical psychiatric condition in this group of patients. You see here that delirium is more prevalent than all other of psychiatric disorder like anxiety disorder, bipolar disorder, psychotic symptoms, and it shows that the delirium is the most important condition in psychiatric consultation in general medical settings. It is understandable when a patient suffers from COVID-19 situation, we can see delirium. But there is a question: is delirium possible to present as a sole symptom of COVID-19 infection or not? There are some case reports that mention that patients came to A&E with delirium without any symptoms of infection. You can see here a case report, a man with delirium symptom, with hyperactive delirium symptoms, came to A&E, and he didn't have any fever, any chill, any infectious symptom. And following the investigation, they found positive PCR test, and they found a hyper-intense signal in MRI in temporal lobe. You can see in this image. So it means that sometimes patient presents delirium as a single symptom of COVID-19. And this issue is more important in elderly. There is a good study was published in Age and Aging 2020 in a cohort study in more than 800 patients, and they found that delirium could be as a presenting symptom of COVID-19, especially in elderly. You can see here in hospital, 25.2% of patients presented with delirium. And the interesting issue is that in community cohort, in community sample, the rate of delirium is more prevalent than hospital. It means that we should be more concerned about the delirium symptom in patients who are not in hospital. And in community, we should be more aware and sensitive about this kind of symptoms. So delirium has different phenomenology, and you can see all of the psychiatric symptoms like anxiety symptoms, depressive presentation, dementia-like symptoms, and psychosis in delirium. Whenever you have a consultation from other department in the hospital and they mention that the patient has anxiety, depression, and dementia symptom or psychosis, you should consider delirium as a probable diagnosis. And for assessment other than psychiatric interview and clinical examination, we have some scales for screening and for confirmation of diagnosis. That in Persian language, we have got CAM and CAM ICU that are available in Persian, CAM ICU and CAM, and DRS that is useful for rating the severity of delirium. So after the assessment and confirmation of the diagnosis, we are responsible for treatment and controlling of the symptoms. It's so important. Usually the other department asks us about prescribing some medication for controlling the agitation, psychosis, and irritability of the patient. But the main issue in the controlling and treatment of the delirium is not prescribing the medication. It's the assessment of patient to find the cause of the delirium. And when we see these patients, we should review all of the documents and history of the patient and paraclinic information about the probable source of the delirium. And after that, with identification of the probable causes, we can propose some ideas, some recommendation to control the symptoms before prescribing any medication. And evidence show that there are 6 risk factors that are so important in pushing patient in a delirium situation. If we review the evidence about the efficacy of medication or non-pharmacological intervention, as a whole, it seems that non-pharmacological intervention is more effective than pharmacological intervention. So we should review the major risk factors for the patient, and we can intervene in these risk factors to prevent or to manage delirium. These risk factors are cognitive impairment, sleep deprivation, immobilization, vision impairment, hearing impairment, and dehydration. And for prevention of the delirium, we should consider improvement, the orientation of the patient, improvement sleep quality. It's better to early mobilize the patient and correcting visual and hearing problems and management of the dehydration. It seems that other than these 6 factors, in COVID-19 situation, the O2 saturation is so important. And we can add these factors to 6 factors for prevention and management of the delirium in patients with COVID-19 situation. So because of the shortage of time, I jumped some of my my slides, and I would like to review at the end about the medication. Usually other doctors ask psychiatrists about the interaction between psychiatric medication and antibiotics or antiviral agent that they usually use for COVID-19 infection. At the moment, you know, in Iran, we usually use remdesivir and favipiravir, and less use, we usually less use the chloroquine and hydrochloroquine. If your patient is taking remdesivir and favipiravir, there is not any harmful interaction between these 2 agents and psychiatric medications that usually used for delirium. You can see here aripiprazole, haloperidol, olanzapine, risperidone, or lorazepam. We usually can use without any significant interaction. But if your patient is taking chloroquine or hydroxychloroquine, it's better to consider haloperidol and quetiapine as factors increasing QT prolongation, and it's better to control the dose and use a very low dose in this condition. And you can see here the Iranian flowchart to control the delirium, and that was published by Iranian National COVID-19 board, and they correctly emphasize on opium and substance use in first level of evaluation, and the second step they emphasize on O2 saturation correction, and then they mentioned and emphasize on non-pharmacological treatment, and at the end they mentioned some medication about the patient condition. Finally, I would like to emphasize on non-pharmacological and liaison education other than medication. There is a study that we did in Imam Khomeini Hospital showed that if psychiatrists try to educate nurses and changing some environmental cues in ICU, they could improve the health situation about the delirium in this condition. And this study showed that after education and environmental changes in ICU, the rate of delirium 30% decreased, and the time of delirium and length of stay 9 days decrease following this kind of intervention. It means that non-pharmacological and educational intervention in delirium as a whole, and especially in COVID-19 situation and in elderly department is more effective than any kinds of medication interventions. At the end of my talk, I would like to remind that whenever we stay in a train station, and we usually hear that they told us mind the gap between the train and station, because if we don't mind the gap, our leg stuck in this gap. And in general hospital, if we miss delirium and if we don't mind delirium, the patient condition and our own stuck in delirium and cognitive problems that comes from COVID-19 situation. Thank you for your attention, and I am here to listen your comments and questions. I don't know, Dr. Etesam, it's better to have a question and comments at the end of the webinar, or we can have at the moment. Thank you so much.
Thank you, Dr. Arbabi, because of your very thorough and comprehensive lecture. I think it's better that we have comments and questions at the end of the webinar. And now we have Dr. Ayati's lecture about geriatric medicine considerations in demented patients with COVID-19. Thank you very much, Dr. Arbabi.
Thank you so much, Dr. Etesam, and all of the audience for your patience. As you mentioned, we are now going to listen to Dr. Ayati lectures. Dr. Ayati is our invited lecturer from Stanford University, and as I knew, he is a geriatric medicine consultant in Stanford University and working in this field. And I hope, as I know, we have a good lecture, and we find new findings about the consideration in patients with dementia in COVID-19. Dr. Ayati, please start your talk.
Thank you so much. Thank you so much. Again, thank you so much for the wonderful presentation. I really enjoyed, Dr. Arbabi, especially your comment about mind the gap. I really enjoyed that. It's very helpful and useful, and is even for daily life. Good morning, everyone. It's around 10 o'clock p.m. in California, Pacific time, but I'm so pleased and honored to be with you all. And you hear me very well, Dr. Etesam, is good? The sounds is good? The quality is okay?
Yes, that's right.
Okay, perfect. Now, again, I'm so pleased and honored to be with all of you. And again, it's such a pleasure. Thank you so much for inviting me, and try to make it at the time. And again, please, if I'm going to be over time, I appreciate that if you just remind me that my time is done. Now, let's just quick, because I want to be respectful to the other speakers as well. There's really, as far as the conflict of interest about topics, unfortunately not. I'm not getting paid by any pharmaceutical or biomedical company, and technically I don't have any plan for my retirement, which is not good as well. But I just wanted to start with what we are seeing these days as our life, and this is exactly what is happening to all of us in the country. And again, I always love from William James, the deepest craving of human nature is need to be appreciated. I mean, at least a moment for all people, especially all of you, and in our side, the people on the front line to fight with the COVID-19, which has extreme again, PTSD for all of us, especially the healthcare providers all around the world. And again, sadly, I know that Iran is still involving with another wave of the COVID-19, and that's again and I feel really the sympathy for all these healthcare workers that in front line and they're dealing with the patient, and we all been in this situation. We just got rid of from the waves in United States. We're expecting another wave, but at least we are a little bit better these days, but we are ready for another wave. Everybody knows that the next wave is coming. What happened in between the December 2019 and January 30th, 2020, you guys are aware of that. There was a major global disaster happen as at the end of the 2019 when we identified the cluster of the pneumonia in Wuhan, the city of the Hubei, the province of China. It's rapidly becomes something that we face in February 2020 without preparation globally. We haven't been prepared for this pandemic. We never had opportunity to really deal with the pandemic in the world. And suddenly every single country, and I think Iran was one of the second or third country actually, and then later United States, we all faced with this huge change, which technically made something new. I always make it as my comments in lecture, and this is not the comment from me. Medicine from now, for all of us practicing in medicine, is divided to two pieces. Before COVID, after COVID. Like in the past, we were talking about the Harrison textbook of internal medicine, the one of the new editions that we get in. This is done. The medicine right now has a new definition. Post-COVID, prior to COVID. And from now, we're actually going to design a new medicine, especially now we're talking about, especially between the all neurologists and psychiatrists, there will be totally new definition. I promise you in the next 5 years, we're going to have DSM for just the COVID in the psychiatry. And we're going to have a totally new neurodegenerative disease that is related to the post-COVID. And that's something that's going to happen in the medicine in the future. This COVID story, it hasn't been finished. We're just in the beginning of that. As we know, the geriatric populations are the highest rate among all the patient. We know the number. It's been more than a year we're dealing with that. Middle-aged and older people are most commonly affected people. But the only thing is that, yes, we know the middle-aged people that are affected, younger people can be affected as well. We technically have mainly range of like, for example, 49 to 56 years old, but mortality and complication is with the geriatric population. Starting from Wuhan on January all the way till April and March and April of 2020, we have the Chinese Centers for Disease Control and Prevention. And we see that the majority of the fatality that they see, around like 8 to 15% of this population between the age of 70 to 79 and 80 years older. We were just dealing with that when we had the hitting in the United States, which we had the majority of our numbers of the mortality is actually happened in older adult population, which is definitely have a lot of comorbidities related to older adult population. But today we're just technically talking about demented people, the people that they didn't know what's happening in this world. They just had dementia and suddenly everything has been changed. All the memory cares that has already been locked down. They're always been isolated, but they facing new things in their life. They see now that all the caregivers and the nurses having the mask on. Everything became so scary. We just talk about delirium. Or face was the trigger for their delirium. When they see us in an N95 mask and coming, then they really have no identification of what's going on around that. What happened? They just have the dementia and suddenly all the doctors have the gown and the mask and the face shield, and that just increased the risk of the delirium and behavioral disturbances. In reality, which is a very interesting review, is one of the very good friend of mine in University of Manchester, Dr. Howard, which I've been pleasantly work with the group of the Royal College of London and the University of Manchester for Geriatric Workshop, which is running by Dr. Andrew Elder, who is the chief of the Geriatric Internal Medicine of United Kingdom. It's exactly the things is happening, COVID-19 and dementia, the best deadly combination. These two scary altogether makes the demented people the highest risk of the deadly because they have all the risk factors that we are expecting. When we look at the UK data, which they have a lot of elderly people because of the age populations, because when the pandemic happened in the United Kingdom, suddenly the care home, which is the definition of a skilled nursing home, and also care home, which is like assisted living facility affected, they see in the Office of National Statistics in United Kingdom, from 17,116 patients they actually had at that time died in England in April 2020 with dementia and Alzheimer's disease recorded in their death certification. The number of the death nearly 3 times more than expected compared to 5 years from the April, means that they definitely see that the number of the people died of dementia and Alzheimer just in April 2020 has been increased significantly. Remember, April 2020, many countries, even the United States, we had a problem with the testing and the kit of the COVID-19. RT-PCR was not very available like today. And that at that time, just the sudden surge of the COVID-19, which is true. It is exactly something we see. The other finding that is very interesting, as Dr. Arbabi was just mentioning, but one of the interesting topic, for many years, we all been working on a dementia expert people, trying to educate the doctors all around the world to at least avoiding as much as we can for managing of behavioral symptoms related to dementia, to not prescribing as much as we can psychotropic medication and antipsychotic medication. We try, as Dr. Arbabi was mentioning, very nice, and I really love their article that it showed in the presentation. Try non-pharmacological method, try to something to not be affected with medication. But suddenly in 2020, the total number of, which is very interesting because in the United States, you can see from selling market. I mean, pharmaceutical company, they're so happy because they sell a lot of quetiapine. They sell a lot of risperidone. And that's actually the stock, their stocks going up, which makes them more profitable and rich. But this is horrible because for years we were trying to find, please do not prescribe antipsychotic to people with dementia. Try to use another thing. And suddenly we see, wow, the raising the number of antipsychotic medications going up just in 2020, when we have the middle of the heart of the COVID-19. And again, this is something we see significantly in this population. Dementia, it's the saddest things happening to the people. The pandemic, yes, you can always do that. You can do isolation, you can do quarantine, you can technically take care of the infection disease. If we have a united protocol for, as far as like a health protocol in the country, we always able to manage the infectious control. But dementia is still the problem. Every 3 seconds in the world, somebody's getting dementia. Dementia, it's technically is a pandemic of aging society and something that is cooking in all around the world. Now we talk about COVID, there's a pandemic. Everybody says, oh, COVID maybe 1 or 2 years, after 2 years, we're gonna be fine. Dementia will be your guest forever. It's just, unless if something's gonna happen in science. We're already in the middle of pandemic of dementia in the world. And I can tell you, we are dealing with a lot of stuff these days. We talk about global warming, we talk about cost of healthcare in the world, we talk about the aging population in the world and the cost that we have. Dementia will be the #1 problem in every single politics of the countries in the future, because the cost of demented people is going to be extremely expensive. The cost of taking care of demented people will be more than the cost of the building any medical school or any medical centers in the world. It's trillions of dollars just in the United States that we have to pay to family to take care of somebody with dementia. It's a 24 hours care. And this is something that we are already facing with that. An interesting thing, when somebody has severe COVID presentation, we learned that COVID presentation is risk factor. Who getting the severe COVID case? So somebody is old, obese, cardiovascular disease, hypertension, and diabetic mellitus. Interesting. Somebody has diabetes, hypertension, cardiovascular disease. Who is going to be the risk of Alzheimer? Same people. Like in Alzheimer and COVID, they are both They are carrying the same risk factor together. It's like that they're husband and wife, their partner, being the partner for a long time, but we didn't know about COVID. We just learned about COVID, but we had dementia already on our table. This monster was already exist in this table, and we had that. And this is what we have. What else in dementia makes the COVID cases to become more complicated and more difficult? Something that we know, polypharmacy in elderly people. We know it. We just know that is the huge issue that we have faced for many years. People are getting older. The doctors, we become more diagnostic and therapeutic for every single problem. We try to throw medication to just the two things. We should want to have an answer for a patient. Number two, we want to make the people to be satisfied. That's why majority of elderly people these days, they're suffering from polypharmacy, multiple medications that they are taking, adverse drug reaction, drug-drug interaction with each other. Many of these medications, I mean, I'm in the middle of my colleague, both in psychiatry and neurology, and they both hate anticholinergic side effect. They know that how much this anticholinergic side effect can affect them neurologically, functionally, especially as far as like a psychiatry wise. It caused one of the major cause of the delirium, that it's anticholinergic side effect. People comes with urine incontinence. Majority of dementia people have urine incontinence. We give them what? Anticholinergic medication to stop the urine incontinence. We make them delirious. Boom. It's like a cascade of something happen. I just make it, this is the cartoon. I wrote a book years ago, Paths to Healthy Aging, and this is one of the chapter that I wrote. It was the cartoon that I actually got it, and it was very nice. And there's a guy went to the doctor and say, the problem is you're over medicated. Luckily, their drug can help you with that. And that's a sad story for many of elderly people right now in the world, that we are knowing that. We try to medicate the people. And this is the same story for people with dementia as well. When we look at the dementia, people that they come with COVID-19, when we look at the general geriatric presentation, what we see definitely, as Dr. Arbabi was mentioning very well, atypical symptoms. I mean, it's not about that the person becomes more forgetful. It's about definitely more agitation, more confusion, more disorient. They don't have fever, they don't have sore throat, they don't have diarrhea like the other COVID people they have. They don't have like a lack of the taste or something. The people with dementia cannot present themselves that I don't smell anything, or I cannot taste anything. They're just going to be extremely agitated and confused because they cannot eat anything. I have majority of my patients with I take care of them with dementia. The time when we found they have COVID, they called me and said nobody eat anything at memory care. And for 2 days. And I said, okay, well, should we test them? We test them. Majority of them, they've been positive. That was last year. But again, it's just a situation. They don't drink, they don't eat. They start to have refusal of care. One of the major things that for ADLs, there's definitely going to be for daily activity, it's going to be the main thing. This is why even Alzheimer Association in 2020, which I was also part of the panel of the, to giving some guideline to the caregivers, that we have technically told them last year that for your patients, your residents in your facility, your caregivers, the symptoms of Alzheimer right now with COVID is not fever, is not cough, is not change of the taste, is not diarrhea, is just a worsening of confusion. It's going to be refusal of the care. If somebody has the symptoms, please call us. We're going to come and do the test for them. This is why the presentation will be very different. Now, when it comes to facility, these are the pictures that we've seen, especially like in many countries or United States. Many of these people for months, they've been on isolation. As you probably know, in the United States, we just opened the assisted living facility and memory care from last May. There've been a lot of fight about that. There are a lot of people, they wanted to do it. There was a lot of politics. There was between the presidency of Trump and presidency of Joe Biden. There was a big fight in the United States here. Everything becomes political, sadly, something that should be just medical, everything just running for their own purpose. But finally, we able, after we reach almost to 70% of vaccination in like a state of California, I can talk for myself in the state that I live, then we start to opening up to the memory care and assisted living facility. It is very sad. Many of the families, when they went to see the loved one with dementia, they couldn't recognize them. Their dementia got worse in just 1 year. Isolations really killed them. But there's nothing else we could do because we didn't. That's exactly in my first slide I said. We were not prepared for pandemic. It seems that we were being like everywhere in the world. We just we all sat and watched what's going to happen. Now, the challenges in treatment, as again, I'm so happy that Dr. Arbabi also mentioned about some of the things. It was a lot of challenge that we had with the people with dementia because there's a lot of drug-drug interaction. Look, again, the chloroquine and the hydroxychloroquine, Plaquenil, when it came, it was just a joke. We know that medication is just really not effective. It's a lot of cardiotoxicity. It became such a politics medication. I mean, it's just so sad. Like the previous former president of the United States with no medical knowledge came to the TV and say, oh, I'm going to take the Plaquenil, hydroxychloroquine. I mean, it's just the fun. It was just a joke. Somebody with no knowledge talking about medication that he doesn't know. And suddenly everybody is starting in America, even the dentists start to prescribing Plaquenil, hydroxychloroquine for themselves. And everybody giving prophylactic to the family. For demented people, I just getting a lot of call. Should we start hydroxychloroquine for loved one? The answer was no, not at all. I mean, they already have a lot of cardiac toxicity, and definitely we should not give them. And there's a lot of the drug-drug interaction. Many of these people, there were most of majority, I mean, I think probably more than 90% of all people, they're already taking one kind of cholinesterase inhibitor, either donepezil, either rivastigmine, either galantamine, and then definitely has some effect of AV node. And then if you give them some of this medication, you increase risk of the AV node or blocking them. That's definitely, you need to have EKG. We have mortality for these people. Memantine, and on the other side, or Namenda, it has lower risk of pharmacokinetic interaction and is probably much better for people with COVID and the same time Alzheimer. And again, as Dr. Arbabi was mentioning, and there is some potential interaction between antipsychotic and antidepressant with azithromycin, which is the French people use it a lot, and chloroquine and hydroxychloroquine and other medications, antiviral that we use, but not as severe, but something that we know. People in Spain, they were thinking about the cognitive and neuropsych manifestation of COVID-19, especially in elderly with dementia. And it's very interesting because what they see, it's more insomnia, anxiety, especially in COVID, post-traumatic stress disease symptoms, psychosis, and mood disorder in several reports that happened, especially in Spain. And the group that actually, I know them very well in Madrid, they actually started to collecting all this data and telling us about all this data happening. And it is very interesting because even in a study that a global health collaborative platform, actually, including medical records of around above 40,000 people that they've been COVID-19 positive, mainly in the United States, like 76%, is actually shows that one quarter of them, they really have neurological and psychiatric manifestation rather than any of the other clinical medical symptoms, as Dr. Arbabi also was saying, that is happening. There's many things, many mechanisms was there. Definitely there's some sort of the, brain viral infection, which is less affected, majority of them. It can be cerebrovascular ischemia that we see that, and the hypoperfusion in the brain causing a lot of the neurological manifestation. The main thing is a systemic inflammation, which we talk a little bit on the last presentation. Definitely, if they go to ventilation, if they have ARDS and they have peripheral organ dysfunction, and definitely as we discuss pharmacological side effect can be the cause of that. And these are some of the study, as you see in China and many other places, that in Spain, Italy, France, and you can see the numbers of the people that for example, you can see significant psychiatry symptoms in the age group. And when they're looking at like a MPI index, neuropsych index, and they can see definitely the very different presentation on that side. Now, and then what we see, as we have on the previous presentation, that we have majority of the symptoms, as again the last presenter was mentioning, Dr. Arbabi, we had delirium, either hypoactive and hyperactive. But again, when you look at the fever, cough, and dyspnea, there's still like 39, 11, and shortness of breath at 36%. But again, majority, it goes to neurological and psychiatry manifestation of the COVID in the demented cases. And one of the very interesting, because I love the fact that we have some theory about the delirium, how's the mechanisms of that. And it's very interesting because the people in Italy, the University of Pavia in Italy, actually they did an analysis of the immunochemistry to detect the COVID lymphocyte, astrocyte, endothelium, and they're looking at to see what is exactly happening when they have the delirium. And it's technically the neuropathological alteration that they see in these people. And it's a very interesting, as exactly was we're mentioning in the previous presentation, mechanism is very inflammatory. Rather than the cells of the COVID is actually going to go sitting in the brain. And that's very interesting. It's a systemic inflammation, which technically going to come to the situation that if we use anti-inflammatory, can we prevent, or can we at least treat the acute delirium manifestation, even in the people with the COVID-19 in demented people? That's a theory that now pathologists is putting in front of us. But we know, it's so hard to use anti-inflammatory for people with dementia, because on the other side, you can flip on the other side. You can actually increase, like for example, you give them IV steroid in them, and you make them very anxious and you make them very hyperactive. But the theory is inflammatory, and it's how much we can actually get help with this inflammatory treatment. That's something that we can see that. It's very, very common, as we said, 55%, and the COVID-19, we have definitely delirium, which is significant. But the other situation is always less than this, which put at the COVID is one of the things for delirium. Let me tell you something. I've been a member of the American Society of Delirium for many years. President of American Society of the Delirium is a very good close friend of mine, Dr. Jose Maldonado. He's the chief of the Delirium at Stanford, and he's like a god of the delirium in the United States. The majority of his study, everything's done by Jose. And Jose and I, we have a great relationship for 11 years working together. We built actually the CAM protocol in Stanford Hospital from 2011, actually, when I started there with the CAM and delirium consultation. And again, it's very interesting because Jose and I were just chatting about this, and he was telling me that it's delirium. We always know delirium dementia is the two flip of the coin, but it's a very interesting thing about delirium that COVID is really showed us that what's the monster of this delirium, what's the disaster of this delirium that we are facing, and how difficult and challenging can be to manage a delirium patient, which is true. It costs a lot, which is in the next slide, as you see, at the huge cost of the healthcare system for elderly people in the United States, just a delirious patient. It's so hard. You have to have a special room. You need to environmental change. They're not able to be released from hospital. They're dangerous to himself, their others. They are very confused. Family cannot taking care of them. And again, cost of healthcare is very expensive in the United States, and it's very ridiculously expensive. That's why every single day when they're in a hospital, there's going to be a huge burden of the healthcare system and the social security system for just keeping these delirious patients in the hospital, compared to the many other things that we have. But again, delirium is reaching very closely to cardiovascular disease. I'm very sure in the next 10 years, 20 years, delirium will be ahead of the cardiovascular disease as just for the cost of the healthcare. And again, as we talk about it, one of the problems that we've seen is antipsychotic prescription during the COVID, which we talk about it. It's a disaster, it's a mess. And again, very, very important that we already started in the United States to having the seminars and education, exactly like the same thing we have. bringing the doctors again and say, I know that you're facing with delirium. I know you're facing with the demented people, that now they are worse in the memory care and the home, but please, 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 psychotropic medication should be under a guideline to how to use it, how to prescribe it, how to increase the dose, how to have a therapeutic goal, because this is one of the problems. We always have the goal, how we treat the people, but somebody has the behavioral disturbances related to dementia. And this is something that we have to be very careful, and especially you and I, we all knowing the use of the antipsychotic medication, especially atypical antipsychotic medication, and typical as well, is always increased risk of cardiovascular mortality. We need to educate the family about that. If they are okay with that, we do that. Now, in Iran is very different, but I remember the time when I was there. But in United States, we always have the barrier of the legal and malpractice for us. This is why for every single antipsychotic prescription that we do, again, what I teach to my students, to my residents, to my fellow, is please make sure you have a good documentation of conversation with family. You explain to them, why are you giving risperidone to this patient? Why are you giving quetiapine to the patient? What's the goal you're going to get from it? And what is the percentage of the treatment? Like, this is a very important thing. You know, I know, majority of people think when the loved one get antipsychotic medication, they will be a happy person again. That's never going to happen. But at least we have a goal that we decrease the symptoms for 50%, 30%. We need to educate the nurse in the hospital that they know, or in the nursing home and the memory care, that this is the goal. We never able to reach to the zero. And this is the other topic that I like to talk. Now, frailty is part of the things we see in the COVID-19. And we know that is exactly frailty and mortality in the people with COVID. It's huge. Now, doors are open. The elderly people who are affected by isolation and demented people, they came out, they're all frail. We know that. And the frailty is definitely adverse to the health outcomes. Increased burden of the symptoms of weakness, fatigue, medical complexity, reduce the tolerance of medical surgical intervention, and definitely there's a systemic inflammation, endocrine, again, dysfunctional, and also immune system as well. It's caused the frailty. We know the frailty has a mechanism, and that mechanism is very well fit with somebody who have COVID-19, inflammation and immune system. We know that definitely effects of the C-reactive protein, we have IL-6, and many other things in frail elderly people, it's affected by that. And we know that especially IL-6 as the transcription factors and also the signal transducer definitely has adverse effect of the musculoskeletal system. That's why a lot of people, they have shrinking of the muscles, they get more weakness, appetite is getting poor, they have the dysfunction for the immune system, they have more prone to get pneumonia, more prone to get flu, and then definitely affects them to get anemia as well. And definitely we have immune system activation, which causes clotting cascade, which definitely it makes some of the factors like factor VIII, D-dimer, and all this stuff effective, and makes them more.
Dr. Ayati, sorry to interrupt you. We have 3 minutes.
3 minutes. Okay, I'm done. I'm almost done. 3 minutes is actually done. Thank you so much for reminding me. Now, I wanted to have my last slide will be post-COVID people. Now, these demented people, many frail people, they got COVID. What we see in the COVID people that that in the people they have is at least 20% they have ongoing symptoms 5 to 12 weeks after that. 10% had at least one ongoing symptoms beyond the 12 weeks. And it's very interesting because many of them, they have respiratory symptoms, and many of them still have the shortness of breath, and they have the oxygen. But what I wanted to say is here. It's with a lot of people that they have pneumonia and many other things. This is what I wanted to say. One of the things that we have is the neurological symptoms. And I can tell you, as a geriatrician, even today, this morning, I was in my clinic and I see like 3 post-COVID people with dementia. 2 of them was Lewy body. All of them complaining of a lot of worsening symptoms, insomnia, headache, depression and anxiety is getting worse. Fatigue is actually getting worse. We see more seizure than we saw before, in especially the post-COVID people, that they're completely recovered from COVID, and we see more movement disorder, more Parkinsonian. We just have the two people with the Lewy body that just quickly they get more Parkinsonian feature, which we see them, but it just got worse quickly after the COVID, and definitely some brain fog in that. And again, anybody is aged more than 65, anybody has visual impairment, Parkinson's disease, Alzheimer, prior stroke, any history of psychoactive medication, polysubstance abuse, and again, longer stay in a hospital, risk for rehospitalization. These are going to be the neurological, and I think the next speakers will talk more about that. And this is going to be an ongoing problem. This is why I said medicine will be to after COVID, and even neurology books will be adjusted based on the post-COVID. What should we do for the future at the end is education. Education for public, for people to know, understanding about behavioral symptoms related to dementia, as we discussed, avoid polypharmacy. And a very, very important thing, beside of geriatric assessment, it's about goals of care. This is one of the most important things in the United States, which is, that's my last slide, that for the people understanding when it's time to go and when it's time that they have advanced disease. Again, I'm working both geriatric and palliative care, and I can tell you for sure that this is one of the most important topics. What matters? This is one of the M that I teach to my student. Always ask the patient what matters. What's going to be the consequence? Where we're going from here? If the quality of life is already poor, are we going to continue to hospitalize your loved one, give them more medication, or really just let them to go peacefully by nature, not inducing by us, but talking about goals of care, providing comfort as we can, and let the nature take care of it by itself. There's going to be the time that medicine will not be the answer. And we know in medical field, medicine is not always the answer of everything. I just wanted to thank you so much. And this is my email. And again, if there's any question, I'd love to answer that. But thank you so much for this time. And again, I'll be happy. I try to maintain myself to be awake, but I'll be happy to be here still and be in a question and conversation. Thank you.
Thank you, Dr. Ayati, for your wonderful talk. I think at the moment we can save the question and comments at the end of the webinar. And I think lots of issues you mentioned are so interesting, and some of our colleagues have comments and questions regarding your talk. So we are going to move for Dr. Etesam lectures. Dr. Etesam, who is assistant professor of psychiatry, and she is the head of geriatric medicine department in Tehran University of Medical Sciences. And Dr. Etesam is going to talk about the long-term effects, cognitive effects of COVID-19 on the elderly. Dear Dr. Etesam, please start your talk. Thank you.
Thank you, Dr. Arbabi. Do you see my PowerPoints?
Yes, I can see here, and I think the other as well.
Yes, and thank you, Dr. Ayati, for your enlightening and helpful lecture. I enjoyed it, and I appreciate that. My presentation is about the long-term cognitive effects of COVID-19 on the elderly. We have been faced the COVID-19 pandemics in the last 1.5 years. And still it's said that about 40 to 50% of the patients are asymptomatic, but we have seen a lot of patients who have been involved of strong inflammation, cytokine storm, and a small portion of them have been faced ARDS, septic shock, multiple organ failure, and death. And now we know that the acute phase of COVID-19 lasts up to 4 weeks, but there's said about some continuing of the symptoms of COVID-19 infections in some people. CDC had a report about continuing the symptoms in 5% of the people in several months after the acute phase of the illness. And the first time the term of long COVID syndrome was used by a woman named Elisa Chirico from Italy, which talked about it on Twitter, and in May 2020 about her experience in continuing the symptoms after recovery of the acute illness. There are some other names for this sequelae of COVID-19, such as post-acute sequelae of COVID-19, chronic COVID-19, long hauler patients, and post-acute COVID-19 syndrome. Amenta and the colleagues said that the post-acute manifestations on COVID-19 last about 3 months after the acute illness, and they say that there are 3 categories for the symptoms. The first category is the residual symptoms that persist after recovery from acute infection. And the second is organ dysfunction that persists after initial recovery. And the third category is when new symptoms or syndromes develop after initial asymptomatic or mild infection. And if we want to look at common manifestations on of long COVID-19, we see in neurologic symptoms, brain fog as the most common symptom that we will talk about more. And pulmonary symptoms that the most common are dyspnea and cough, and the cutaneous symptoms that are between them erythematous rash and urticarial rash. And psychiatric symptoms that we all have been observed in the last months, such as depression, PTSD, and anxiety. Cardiovascular that are among the most severe symptoms of the disease, and a lot of time those lead to mortality in COVID-19 patients. And among them, palpitation is the most common symptom. And general symptoms such as fatigue and myalgia as most common. And the other symptoms such as joint pains, peripheral neuropathy, and peripheral limb ischemia. The early follow-up studies that was performed about 3 months after acute phase of the disease introduced fatigue and dyspnea as the most common symptoms, but other studies that was performed, for example, this study that is performed about 7 months after the acute phase of the disease, it has introduced fatigue, muscular weakness, and ache in 78% of the people, post-exertional malaise in 72%, cognitive disturbances in 55%, with an overall decline in quality of life of the patients in 44%. Some of the patients experienced a flare-up of neuropsychiatric symptoms or appearance of new psychiatric symptoms, which is reported in 16 to 80% of patients with long COVID-19. Many survivors of COVID-19 infections complain about some cognitive symptoms. If we want to have a definition of brain fog, which is cognitive symptoms after the acute illness, means the constellation of cognitive function impairments such as confusion, short-term memory loss, dizziness, and inability to concentrate. The common areas which are involved in long COVID-19 are episodic memory, attention and concentration, and executive function. We can expect all of them in the patients, in many of the patients, even in the patients with milder COVID-19 infection, not all of the patients who have more serious symptoms. And in many of time, they're not associated with fatigue, viremia, hospitalization, acute inflammation, treatment, and depression. They can be independent of these factors in patients after the acute phase of the disease. In a systematic review and meta-analysis of 350 studies about patients with COVID-19 infections, the prevalence of neurological symptoms in the elderly population has been introduced in this table. As you see, acute confusion and delirium is seen in 94% of the patients, and after that fatigue in 96%, myalgia 90%, dizziness in 83%, and headache in 90% of the elderly population. And we know that a lot of these neurological symptoms are related to existence of cognitive decline, later existence of cognitive decline in all of the patients, especially the elderly population. Other neurological symptoms that we see in the patients are neuralgia, enhanced physiological tremor, Guillain-Barré syndrome, muscle weakness, loss of smell and taste, epileptic crisis, stroke, severe encephalitis, and some patients experience encephalopathy, agitation, and corticospinal tract signs. And in several cases has been reported subtle motor and sensory low limb deficit. The relationship between neurological symptoms and cognitive decline in COVID-19 patients are bidirectional way, and especially the severity of the illness between them. There are some correlations and some factors as a predictor of neurological symptoms and as a predictor of cognitive decline in patients with history of COVID-19 infection. As you see, serum antibody titer, blood lymphocyte counts, decreased CRP, impaired renal functions, poor oxygen saturation, increased needs for ventilation, D-dimer levels, and hyposmia, which has introduced as an early marker of cognitive decline and as even a prodromal marker of appearance of Parkinson disorder in Parkinson disease in people who have been faced COVID-19 infection. But the strongest predictive factor of neurological symptoms are age, comorbidities, and longer hospitalization. If you want to look at the whole factors who contribute in the cognitive dysfunction in these patients, we have some risk factors. At first, we have genetic factors. It's been said that ApoE4 gene, which is a susceptible gene to cause dementia, can be a risk factor for being infected with COVID-19. And also in aged people, hypertension, as Dr. Ayati mentioned, diabetes, obesity, COPD, smoking habits, and having inflammatory disease and being infected with previous infections such as HIV, MERS, SARS, or others infections. These are the risk factors, and you see that a lot of these factors, these risk factors, are seen in at-risk people for dementia and MCI. So all of them have a two-way direction with COVID-19 infection and also a later cognitive decline in the patient. The other factor is pulmonary. We know that the virus enters the epithelial, bronchial, epithelial cells and pneumocytes via S2 receptor and causes hemorrhage, edema, alveolar valve thickening, so cause lung damage. And the lung damage in these people and also in the other people with COPD and obstructive sleep apnea causes a chronic hypoxemia, which independently and indirectly can be a factor to evolution of cognitive decline in the patients. Some other patients will face with more serious symptoms and ARDS, and they need to mechanical ventilation. In ARDS, it's a need to maintain O2 saturation as low as 88%. That it itself causes chronic hypoxemia in the patients and is the other factor which is involved in existence of cognitive dysfunction in the patients. And the patients are agitated and we are scared that they can harm to themselves and other staff, and so they become more sedate and give them sedative agents that they cause more chronic hypoxemia, and all of these are minor pulmonary factors that are involved in this. And the other factors are systemic and neurologic factors. When we have cytokine cascade, we have hyperinflammatory status, we have destruction of blood-brain barrier, systematic vasculitis, coagulopathy and thrombosis, astrocytes infection, mitochondrial activation, and oxidative stress. We have delirium for all of this, and delirium itself, as Dr. Arbabi said, can cause cognitive dysfunction. And associated hippocampal atrophy was reported in a lot of researches, and some of the patients has encephalitis or brainstem involvement. Dr. Vahabi will explain this pathophysiological mechanism, so I'll pass them. And we have some psychological and psychiatric symptoms. As you see, psychological stress, disease burden, because of disease burden and because of the fear of being infected of the virus, social distance, depression, anxiety, PTSD, circadian rhythm dysfunction. However, cognitive dysfunction can be without independently of psychiatric disorders or symptoms, but these symptoms can contribute in cognitive decline of the patients with COVID-19 infection. And also there's a bidirectional relationship between COVID-19 infection and psychiatric disorders. It's been reported that people who have psychiatric disorders are more than the others can getting infected by coronavirus. And when they are infected with the virus, there are some reactions in the body. Apart from psychological reactions to the virus, we have some neuronal and glial dysfunction, and we have a host immune response to the virus. So a massive upregulation of pro-inflammatory interleukins, and the virus persists in the body after the acute illness. So we will have a low-grade neuroinflammation, and we have the role of post-infectious autoimmunity, because the molecular mimicry between virus epitopes and host molecules, such as human myelin, so we will have the demyelinating state in the patients. And also the impairment of the lymphatic system that is a recently known clearance system, the endocrine system or the mitochondrial function, and also the presence of ion channelopathies. Second messenger systems, which affect the expression of gene products such as BDNF, alteration in gut-brain axis, glutamatergic dysfunction. We have low function of glutamate in dorsolateral prefrontal cortex and dysfunction in specific brain areas such as right temporal lobe, connected limbic and paralimbic regions, amygdala, hippocampus, brainstem, cerebellum, and hypothalamus. We have some risk factors of cognitive decline in age people that especially is with them, such as elevated angiotensin signaling and subsequently chronic low-grade inflammation, which I talked about, that develops it in the age people. And we have medical comorbidities that themselves are the risk factors for cognitive decline. And also we have a gradual decline of blood-brain barrier in normal aging, which may enhance the effect of coronavirus, and also the underlying pathophysiology of neurodegeneration in brain aging. The research say that we have an accelerating dementia pathology after infection with coronavirus, apart from the factors related to viral infection that that talked about. We have the time of isolation and quarantine, levels of loneliness and depression that contribute in dementia pathology in these people. But the key unanswered questions are how much brain damage is caused by direct effects of virus on the CNS parenchyma or vasculature, how much indirect vascular damage to CNS is caused by immune activation, and how much is hypoxic ischemic injury attributable to the extracranial effects of the virus on the cardiovascular and respiratory systems. So why is it important to screen the elderly people's cognitive performance? Because as we talked about, all patients could develop worsening of cognitive function after COVID-19. And cognitive decline can be an insidious process after this insult that patient face with. And the cognitive function assessment is undervalued. We have not screening for the patient in our routine clinical practice. So in the most cases, cognitive decline is reported by the patients or the family caregivers. And when some people have had some neuropsychiatric disorders or some cognitive disorders before, it will be more debilitating for the patients. And the persistence of clinical disorders, such as MCI and vascular dementia, can easily go unnoticed or to be attributed to psychological reactions, to anxiety and fears that triggers by the pandemic. That's while cognitive decline can affect basal and instrumental ADL and reduces the degree of autonomy of the older people, and increases the burden on the caregiver. So we should be cautious about the diagnosis of cognitive disorders in the patients. We have some approaches, such as the radiological approach to the brain. There are some reports of hypoperfusion in frontotemporal region of the brain, hypometabolism in limbic structures, frontal and orbitofrontal cortex, and cingulate gyrus and thalamus and hypothalamus, and also structural brain abnormalities in thalamic and temporal regions. We should use screening methods because without that, in most of the times we may not notice existence of cognitive declines in our patients, especially in Iran. And we should avoid cognitive testing of individuals who have active symptoms, because some of these cognitive symptoms can be temporary and will be better after the remission of the symptoms. And we can apply some targeted cognitive testings that is focused on the functions of vulnerable brain regions. And we can have a smelling test because it's been introduced as an early marker for cognitive decline and Parkinson disorder. Some screening and diagnostic evaluations are MoCA. MoCA is a good test that can distinguishes MCI from dementias, and applicable test, and STMT, which evaluates process information. Speed of processing information is the other good test, and Edinburgh test. And we should always use a specific test which assess attention executive functions, learning and memory, as well as the speed of information processing for the COVID-19 patients who are suspicious to have cognitive decline. We have some differential diagnoses, and we should be aware of them. For example, misdiagnosed cases of delirium, transient cognitive impairment, which will be in remission after the acute phases, and myalgic encephalomyelitis, some chronic fatigue syndrome, which is reported in COVID-19 patients, and other previous infections such as MERS and SARS. And however, fatigue can contribute in cognitive decline, but we should differentiate it from the cognitive decline. Common principles for management, we should consider that maybe the person has been infected with coronavirus, and because of that, her or his neuropsychiatric symptoms has worsened. And we should expect more probability of coronavirus infection in patients who had psychiatric illness before. And also we should expect more neuropsychiatric and medical consequences if these people have coronavirus infection. It's better to monitor symptoms longitudinally at regular intervals. And in addition, we should screen and correct comorbidities which affect cognition of these people, such as depression, anxiety, fatigue, sleep disturbances, and reversible causes such as nutritional deficiencies, endocrinopathies, metabolic derangements. And also use some pharmacological therapies, beneficent pharmacological therapies, and not psychotherapies with harms, as Dr. Ayati talked about that, and need to highly coordinated care with other specialists, and we should use telehealth to expand access to mental health care. And we can educate the patients about vascular risk factors who are involved in COVID-19 infection and more serious symptoms of it, and other people about regular exercise, eating a heart-healthy diet, reducing stress, applying stress management methods, improving sleep, and following other recommendations for reducing risk of heart attacks and strokes. And additional actions are among the future directions, that all of the actions that would be useful for improving the health of the COVID-19 patients. We should be aware of timeliness, because cognitive dysfunction, if it's diagnosed late, maybe we cannot be helpful for the patients. So we can increase the awareness of all, both healthcare professionals and patients and their families about the importance of assessment and management of the symptoms. And we should continuing our investigations about this matter. And this is my last PowerPoint. There's still some questions remaining related to long COVID about the risk and protective factors. How long does it last when it is caused by COVID-19? The biological underpinnings, the rating measures, which are the best for screening and diagnosing of cognitive decline, and the beneficence of digital monitoring and track the course of the condition, the role of psychotropics, and the importance of cognitive and functional rehabilitation for the patients. Thank you very much for being patient and hearing my lecture.
Thank you, Dr. Etesam, for your informative lecture. And I think this issue you mentioned, there are questionable ideas that we need to consider them in our clinical practice. Let's move to Dr. Vahabi talks. I would like to introduce Dr. Vahabi. Dr. Zahra Vahabi is Assistant Professor of Neurology in Tehran University of Medical Sciences, and Dr. Vahabi is involving in geriatric medicine and neurology as well, and she's working on dementia special. Dr. Vahabi is going to talk an interesting subject, how COVID-19 changed the brain. I think this would be so interesting for all of us. Dr. Vahabi, please start your talk. Thank you.
Hello, everybody. Can you hear me? Is my voice is okay?
Yes.
Yes.
Can see you and hear you. Thank you.
Yeah. Thanks. It's my pleasure to participate. At the time, I listened the lectures of my colleagues. I have learned more. Thanks, Professor Arbabi, to join us and the management of all sessions, and also your session. I express my gratitude to Professor Mehrdad Ayati for accepting our invitation and for your informative helping, and Iranian doctors excited me. And also thanks my dear colleague, Professor Farnaz, for your effort as scientific secretary of this webinar. And my topic is how COVID-19 affects on the brain. First of all, I show some imaging of some person who infected with COVID-19. The first image is an axial view of the flare sequence in 71-year-old woman with a loss of consciousness. And we can see some hypersignality in periventricular space. And the other page, the other image is about a 61-year-old man with confusion. And we can see bilateral cerebral peduncle involvement. In this view, we can see the hyperintensity in the splenium of the corpus callosum. And the patient is a 66-year-old man with confusion and loss of consciousness. And this imaging is related for necrotizing encephalopathy, and we can see bilateral thalamic lesion and also cerebellum involvement and cortical involvement. And the last imaging is a SWI sequence of a 57-year-old man with confusion, and we can see we can see very small microhemorrhage in cerebellar peduncle, subcortical, and internal capsule and corpus callosum. And as we know, this imaging show many overt pathology, and we know the important mechanism to involvement of the brain in COVID-19 is a microinflammation. It's very important. We know when respiratory and gastrointestinal symptoms was detected, we can see short and long-term neuropsychiatric symptom and long-term brain sequelae. Neuropsychiatric symptoms sign can be anosmia, cognitive and attention deficit, as say brain fog, nuanced anxiety, depression, psychosis, seizure, and suicidal behavior. And we know this may be happen during, before, and after respiratory symptom, and it's independent to respiratory insufficiency resolve. And in some cohort study, in UK and Germany, they detect that after COVID-19, 20 to 70% of patients, even in young adults, they have some brain damage and brain sequelae after their respiratory insufficiency was resolved. We know the important role of ACE receptor in COVID-19 pathology, and we see ACE receptor in airway, epithelium, lung, parenchyma, vascular endothelia, kidney, and also in brain. This figure shows us more detail about the mechanism, how the COVID-19 affects the brain. After entrance of COVID-19 via the ACE receptor, the mechanism of endothelial damage was started. And also due to systemic inflammation, we have a cytokine storms and increased interleukin 6 and interleukin 10, interleukin 18, 1, and tumor necrosis factors. Tumor necrosis factor plays two roles. One, its effect on the blood-brain barrier permeability, and I talk about it later. And the second role is its effect on local microglial activation. And we can see increase in quinolinic acid, increased glutamate, and upregulation of NMDA receptors. And also, we detect that depletion of neurotransmitters such as serotonin, dopamine, and norepinephrine. All of these mechanisms affect our brain cell, and we have neuronal damage, and we have some neuropsychiatric symptoms such as hallucination, memory and learning disturbances, cognitive decline, and also suicidal behavior. So as conclusion, we can say new onset or re-exacerbation of pre-existing neuropsychiatric symptoms we can describe it in two pathways, entering through ACE receptors and systemic inflammation. Some studies are focused on ACE receptors in specific brain areas. For example, they found some ACE receptors in nuclei. They involved in cardiovascular function, in respiratory neurons, cardiorespiratory neurons in brainstem. And also they found these receptors in non-cardiovascular areas such as motor cortex or raphe nucleus. In other study, they found more ACE receptor in expansion cells such as astrocyte, oligodendrocyte, and microglia cells. And in some studies, they found ACE receptor on middle temporal gyrus and posterior fusiform cortex. It's very exciting that prefrontal cortex and hippocampus has less ACE receptors. I return to our figure, and I want to speak about another mechanism, the coagulation cascade. After entrance of the SARS-CoV via the ACE receptor, we have endothelial damage, and so increased warm blood factor, fibrin deposition, and platelet activation was happened. So we have microthrombosis formation and some ischemic and also hemorrhagic events was happen. But it's not means we also only have microstroke, but we have micro ischemic stroke, and this act our brain to change their manner and to show some neuropsychiatric symptoms. And it depends on which Brodmann area are involved in during this coagulation.
Did Dr. Vahabi lost the connections, or I don't hear her voice? Dr. Arbabi, do you hear my voice?
Yes, yes. Dear Dr. Etesam, would you please call Dr. Vahabi to check about the internet connection or?
Okay, sure. Okay.
Thank you.
I come back, Professor Arbabi. Excuse me.
Okay.
My net is disturbed, and excuse me. I don't know which session and which slide I speak about it. You hear it.
You can start from slide 16, I think. Thank you, Doctor.
Thank you, and I apologize all the audience. And the Brodmann due to the coagulation cascade and some microthrombosis, the neuropsychiatric symptom depends on the Brodmann area involved. For example, if the micro-strokes are happened in the parietal, we have some apraxia or other neuropsychiatric and cognitive symptoms. And another theory about the invade of the brain via the some peripheral nerve. We know some patients have anosmia, and there is a theory that a virus can invade the brain via the cryptiform palate and via the olfactory nerve. And in some articles, they said about the trigeminal nerve or vagal nerve. But the evidence about this fact is weak, and it's not obvious than other process and other pathogenesis. And as I speak about the, I talk about the blood-brain barrier, I know tumor necrosis factors affect on the permeability of the blood-brain barrier. And we know the cytokines and complement and tumor necrosis factor can affect on the permeability and of the blood-brain barrier, and they change the barrier. So some inflammatory factors can invade the brain through this. And also we have some organs, circumventricular organs that are located in the third and fourth ventricle. And these organs regulate and manage the content of the CSF. So the permeability of the blood-brain barrier is weak in this area. So some virus and also some inflammatory factors can entrance the ventricular system via this organ, this area. And some symptoms such as nausea and vomiting was occurred due to involvement of
Dr. Etesam, I think Dr. Vahabi's connection is not available at the moment.
Yes, I contacted her and she said that she would come.
Would you please check again with Dr. Vahabi for joining us?
Yes, of course.
Dr. Etesam?
Yes, yes, of course.
In the meantime, I think we can wait for Dr. Vahabi, but I ask all dear audience, if you have any question, you can write in a chat box for the panel, and we can read them and share with the speakers to answer your question. Or if you have any comments, you can raise your hand to open the microphone to share your question. I don't know, Dr. Etesam, shall we wait for Dr. Vahabi, or we can move to next step for the webinar?
I will ask her and inform you soon.
Thank you for break. Dr. Vahabi, are you able to continue your talk or not? Is it connection okay at the moment?
Yes, I return and I can finish my lecture as soon because my net is not stable, unfortunately. I checked before.
Sorry, take it easy, no problem. I think your talk is so interesting, and it's pity we missed it. Please continue your talk till the end. Thank you.
Thanks a lot, your patience, thanks. There is a theory that some RNA of the virus was found in the brain and via the PCR method. But we know it's virus particle was detected in the brain via the contamination of the vasculature. it said that a virus invade the ventricular system, invade the maybe vascular system, but not the neuron or glia. And we can, in this slide, I saw this, I see and I show this conclusion of this theory, that some symptoms is depend on the involvement of the brainstem and ventricular system due to invasion of the virus, maybe, and the other symptoms, long-lasting or psychiatric symptoms, was happened because of hypoxic and systemic inflammation processing. And there is another matter about the traumatic brain injury and the pathophysiology of COVID-19 interaction with the brain is like traumatic brain injury. We can see also some macro and micro hypoxic ischemic injury, and in addition we can see some inflammatory processing, and the combination of this processing produce neuropsychiatric symptom. We can see some suicidal behavior and some odds behavior in traumatic brain injury. It's like the COVID-19 patients, and I saw some patients who have very dangerous and very odd hallucination after, during and after COVID-19 infection, and it's like the TBI patients. And we know if our brain can manage the inflammation with the activation of the toll receptors and some priming and delaying the inflammation response to protect itself. And if we know the cellular and molecular aspects of the COVID-19 brain damage, we can manage and can take the knowledge about how to manage the long-term neuropsychiatric symptoms. And there is some theory of how to we can use some antagonists of cytokine and NMDA receptor, and some anti-inflammatory pathways, and also some quinolone pathway modulator. There is a suggestion that COVID-19 neuropathology, as Professor Ayati said, can help us to understand the pathogenesis and find the method to treat some neurodegenerative disorder like Alzheimer and other neurodegenerative disorder. And it's a new way to understand some other disease. And the last and main question that could these patients be at higher risk for dementia, for like Alzheimer disease? There is no correlation, an obvious correlation with the Alzheimer and COVID-19. But there is many hypotheses and many studies about this effect of COVID-19 on dementia or on Alzheimer. For example, some of these possible hypotheses about the beta amyloid hypothesis. We know beta amyloid is the primary sign of the Alzheimer disease in the brain. When we detect the beta amyloid in brain, we know AD was started. But we know beta amyloid have some antimicrobial peptide, have a role like antimicrobial peptide, and during the COVID-19 infection, brain start to produce more beta amyloid, so it may be precipitate the Alzheimer disease, we don't know. And about the ApoE4, we know ApoE4 increased risk of Alzheimer, and also in some studies they showed ApoE4 can increase infection rates in the CNS, and its effect on the blood-brain barrier breakdown and permeability. So we can decide that ApoE4 can increase risk of severe COVID-19 infection, can induce gliosis and neuroinflammation. And other theory about the ACE receptor, and if we have ACE receptor in some brain part, if can the open door for the COVID-19 to invade the brain, and it can invade the brain, it can the cell death, and so we can have some symptoms of the dementia. And other theory like microglia are activated, and we know some of the injury to microglial cell, it produce the neuronal death, and it's the sign, it's produce Alzheimer or other neurodegenerative disorder. So we know there is many hypotheses and we need some cohort study to show the effect of the COVID-19 on the and on the brain, and it can help to presentation as soon as Alzheimer's disease, like other viral infection, or it's produce or it's initiate and start the new neurodegeneration. And I think it's very important, and we do not ignore the effect of this novel virus and this transient infection and the Alzheimer's disease correlation. I apologize all the audience because of my net interruption. I hope my lecture would be informative. Thanks for patience. It's my honor that I think Professor Noroozian is joining our webinar, and we know she's a pioneer in cognitive neurology and dementia in Iran. Thanks, Professor Noroozian, and thank you, Dr. Arbabi, to help me and to manage this session. And at last, I hope Iranian people would be in calmness and healthy condition as soon as possible. Thanks.
Thank you, Dr. Vahabi, for your interesting lecture. At the moment, we are going to start the panel discussion. Before that, I would like to invite Professor Noroozian to join us and give her lecture about the COVID-19 effects on elderly health. Professor Noroozian, as Dr. Vahabi mentioned, is the pioneer in dementia health and research in Iran, and I think Professor Noroozian's talk will be so informative for all of us. And following the lecture of Professor Noroozian, we will be go to the panel discussion, and there are some questions here, and I will mention with the speakers at the end of the Professor Noroozian talk. Dear Professor Noroozian, please start your talk. Thank you so much.
Do you hear me?
Yes, please, Professor Noroozian.
Yes.
I'm just trying to share my screen and just please
no
give
worries.
me
No worries.
a few minutes time. Thank you. I'm trying to figure out.
Recording in progress. Recording in progress. Recording in progress.
Is there any assistant to?
Your microphone is muted. Dr. Etesam, is there anybody to help Professor Noroozian to share her slides?
Yes, I will speak with Ms. Alaeddini about how to guide Dr. Noroozian to, yes, she said that has sent some information for Dr. Noroozian. Could you see please, Dr. Noroozian, and I say hello to you, and I'm very happy to see you here.
Hello, everyone, and thank you all for staying with us. Dr. Noroozian, if you hear my voice, please share your screen by clicking on the share screen button at the bottom of your panel. It is a green button that says share screen. After that, you can choose your PowerPoint slide and share with us. You are co-host now, so you're able to share your screen with us. Dr. Arbabi, I think while we're waiting for Dr. Noroozian, maybe if you agree, we can go to question and answer. We had some questions from the participants.
Yes, I don't know, Professor Noroozian, shall we ask some question from the speakers until you prepare your share screen?
چرا اونو دارم ولی چون اون مشکل داشت از این استفاده کردم.
میخواین دوباره خانم دکتر این شما.
Okay, there are some questions in chat box. First of all, I want to ask Dr. Ayati. One of participants asked that is there any report or evidence regarding the protective effect of amantadine in COVID-19 progression or not?
Yes, thank you so much. Again, I hope that the situation with Dr. Noroozian is going to be changed, but the answer is, as far as like my knowledge, the answer is no. It hasn't shows any, and again, I should have wanted to ask if Dr. Vahabi has any of the, again, any technically for dopamine agonist, as if when we talk about the protective effect should be in what aspect? Is that infectious wise? Is definitely not. Is it managed to for neurological symptoms related to the COVID-19, especially the COVID-19? The answer is no so far. We haven't seen any effectiveness, but again, as far as like we even don't use it as far as like, especially with people with delirium or any neurological complications so far here. That's why the answer is no. Nothing so far. I mean, there may be some other studies on people are doing it, but as far as I can say, that nothing about either cerebrovascular disease, encephalopathy, especially would we talk about encephalopathy situation, the answer is absolutely not so far till today.
Thank you so much. Thank you so much. I think these questions come from the antiviral effect of the amantadine, and maybe related to use amantadine as an antiviral, and it may protect the progression of COVID-19. But as you mentioned, there is not any.
No, nothing really. Yeah, nothing so far. Yeah.
And we have got some report about the effect of SSRIs like fluoxetine in treatment or protecting against COVID-19 in 2020. But this kind of evidence like amantadine was not approved, and we cannot suggest to use fluoxetine in treatment or augmentation of treatment of COVID-19. Thank you so much. And there is another question. Hamid asked that he had a patient with muscular weakness following the COVID-19 infection. Dr. Vahabi, what's your idea about the muscular weakness following the COVID-19? Is there any report regarding this issue, or do you have any suggestion for treatment this kind of problem or not?
Thank you. We have many complications from the COVID-19, such as other viral infections, such as the involvement of the peripheral system as a Guillain-Barré syndrome. We see many patients. But about the myopathy, we have some myopathic process due to COVID-19, but it's very rare. And the muscle weakness is due to complication of the corticosteroid and the general weakness of the viral infection. And there is no specific treatment for the muscle weakness. And if we manage the viral infection and cytokine storms, we can manage the general weakness and fatigability and other weakness. I think it's the method of the management, not a specific drug for some complications.
Thank you, Dr. Vahabi. Dr. Ara Shafian asked about some components to improve the effect of COVID on brain. I don't know, is there any approved medication or ingredient could protect brain against the COVID-19 effects or improve the rehabilitation phase of the COVID-19, Dr. Vahabi?
For the acute stage, for example, for some strokes or other vascular management, some literature and some experts use anticoagulant, NOAC, for example, and antiplatelet, but it's not approval method. And for the rehabilitation, there is no specific drug, as I read, for the slow down the progression of the brain involvement. But if there is a new method, I can, if I hear from other colleagues, I will be happy.
Thank you so much.
Yeah, there's really nothing. I agree with you. It's really nothing out there. And nobody even suggests, because again, the use of any compound to slow the progress, it should be done in the large clinical trial. Safety of the medication needs to be also, or even compound needs to be very well evaluated. And again, it's so hard. I mean, at least in the United States, there's anything that we want to try, it should be under the clinical trial, and we should see the safety and the approval because it's a big liability as well. But technically, the answer is absolutely, I agree with you. There's nothing actually right now. There may be some sporadic, they're doing some study, but again, COVID is the new baby. Still, we are just learning from this new baby every day. That is something new is coming. That's why, again, we just have to wait. We're just dealing with the 1 year, 1.5-year-old kid that we're still waiting to see the behavioral of this kid right now. I agree.
Thank you. I wonder if Dr. Noroozian is connected to Zoom for giving her lecture or not.
Dr. Noroozian are in the Zoom, but she can't upload her lecture on the Zoom. Ms. Aladdini is talking with Dr. Noroozian, and I hope that it will be managed soon. Thank you.
Thank you. But I think Dr.
I have a comment.
Sorry, Dr. Vahabi. I think, however, Dr. Nooroozian's comments is so valuable, and if the slides are not prepared on the Zoom, we are interested to hear Dr. Nooroozian's comments about the COVID-19 effects in patients with dementia and elderly ages. Sorry, Dr. Vahabi, I'm ready to hear your comments.
I suggest that, like you, Dr. Noroozian speak, and we hear her comments is very helpful for us. And up to now, we use remdesivir, drugs like remdesivir. Other complication of COVID-19 would be less than previous, mortality and morbidity. So we can now, if we stop the virus invasion and cytokine storm, other complication and effect of the virus on the brain is would be less and less. I want to say about it, if we start the treatment of the virus or control the virus invasion, it's may be helpful than found some new drugs or do some clinical trial, for example, many drugs to stop or slow the effect of the virus.
Thank you, Dr. Vahabi. There is some question here that may come from media. But I think Dr. Ayati could answer this question, like, is there any evidence supporting use of mushroom-driven compounds in treatment of the dementia or cognitive problems or not?
No, not really. We know it, unfortunately not. I mean, Dr. Vahabi is also here. Dr. Noroozian is here as well. I mean, and we know there is really nothing we have so far. As you probably know about even the recent medication from the Biogen company, which is a lot of controversial, finally got approval with the loss of fight in the FDA committee. And Janet Woodcock was actually on a really big trouble with approving this. A lot of people resigned from the Committee of Neurological approval for FDA because of approving. But again, as you probably know, the EMERGE trial, even in 2 Biogen trial recently, they are being halted because of the really not any efficacy they've seen after 18 months of the people that did on a study. And the fact is, again, I think the future will be more toward more immunomodulator treatment for the treatment of the dementia, all kind of that. This is going to be the future. I'm actually happy about it because this is a starting point. But reality is that we may see some sporadic study. Again, as you remember, when the COVID happened, the French people says, oh, we use azithromycin plus hydroxychloroquine, and we're so effective. The guy who was the French scientist came to CNN and made a lot of the, he became very popular on his social media, and everybody actually liked his hairstyle at that time, that when he was coming and talking in the social media at that time. But anyway, the story short is that really not any evidence in clinical trial. We should respect to evidence-based. Large clinical trial, we see the data, and then we have a conclusion about this is effective treatment for people or not. I know we are so desperate when it comes to dementia. There's no many other options on the table. People's families are all affected. They're all worried. They are sad. They're paying too much also for the care of the loved one with dementia. But we understand that this is true. But we are, as a practitioner, as a scientist, as the people that the people rely on our judgment, it is very, very important, which is we always saying that we should give them the right message. Even if the evidence-based saying there is nothing there, we should tell the truth. There is nothing there. We just have to wait. We have to do supportive treatment, which is very, very important. But thank you so much for bringing up this question.
Thank you so much, Dr. Ayati, for your comment. And I think more than evidence-based approach to this kind of information is so important to consider some conflict of interest regarding the substance-driven compounds like mushroom or cannabis or other kinds of substance-driven formulation. And I think we should much mindful regarding this kind of suggestion. Thank you so much. And I think fortunately we connected to Dr. Noroozian, and we are ready to hear, Dr. Noroozian, your outstanding comments. Professor Noroozian, I think all of us and all of participants know her very well, and she's a distinguished professor in Tehran University of Medical Science, and she had lots of experience about the dementia. Please start to speak, Dr. Noroozian.
Do you hear me?
Yes, we can hear you and see your slide.
Thank you. Hi, everyone. Thank you very much for your patience. At first, I should say apologize for delaying in starting my speech because of technical issues that we have to struggle with in Iran, and so sorry for the problem. It's really my pleasure to participate in this meeting, and I enjoyed all of the talks. Special thanks to Dr. Etesam because of her efforts in the field of geriatric medicine in Iran. And also, I would like to say welcome to Dr. Mehrdad Ayati. I enjoyed and learned many points from your lecture. Thank you very much. And also thanks to Dr. Arbabi because of providing this valuable link, and his efforts, and Dr. Vahabi because of the great speech. At the end, I would like to mention to some few points. I think it has been remained. Many of the important issues have been discussed in the previous lectures. Just, I think that we have to, as Dr. Ayati mentioned, the history of medicine has faced with a new issue and new milestone, pre-COVID and post-COVID period of time. So I think we have to find the ways to manage the patients with cognitive deficit or behavioral symptoms after COVID infections and hopefully after COVID pandemic. These points that I would like to talk about them have been based on my experiences during the more than 1 year, and the evidences that we see in the literature. For the elderly COVID-19 survivors, we see the categories of two separate issues: cognitive impairment and behavioral disturbances. Next slide, please. I couldn't share my my slide. Thank you. Okay. In clinical evaluation, when we visit a patient, an elderly patient with cognitive or behavioral symptoms, first of all, we should have attention to clinical evaluation about premorbid status, the cognitive reserve, the premorbid neuropsychiatric profile, and past medical history. All of these categories are important to evaluate the clinical evaluation of the patients who has survived from COVID pandemic. Next slide, please. About cognitive symptoms, we first of all, we should think, is it a new onset cognitive deficit, or we see a patient with previous cognitive impairment or mild cognitive impairment or previous dementia? There is a big difference between these three categories. And during this pandemic, we have visited, I think all of us have visited the patients who have converted from MCI to dementia. The next slide, please. The next part is to review the clinical status during COVID-19 infection. Is there a history of hospitalization, ICU admission, intubation, mechanical ventilation, or CPR? And if there is any metabolic disturbances, sepsis, and organ failure, convulsion, delirious state, all of these issues have been discussed comprehensively in this presentation. And finally, about long-standing hospital admission and polypharmacy, which are very important, as Dr. Ayati mentioned. Next slide, please. All of these variables are important to evaluate which patient is in front of us. About behavioral symptoms, we should decide about it as, is it consequences of brain damage? For example, I have patients with stroke, or for example, from any structural brain damage we can see, or is it a BP, actually is it a manifestation of BPSD in a patient with pre-existing dementia? Or is it possible that our patient has a premorbid psychiatric symptoms, psychiatric disorders such as BID or schizophrenia, or for example, personality disorder? Which patient is in front of us? Next slide, please. This is the next slide, please. Next slide. About paraclinic findings, the MRI has a vital role, especially in our country, which, for example, we have not access, as it's not possible for example, CSF measures and very sophisticated paraclinic procedures. We should evaluate the volumetric findings in vulnerable regions, for example, hippocampus or prefrontal cortex, and also DTI findings when the volumetric study may not be very may not have any conclusive points. Especially vascular insults is very important to decide about the patient with vascular risk factors such as diabetes and hypertension, which are very important and very common. Next slide, please. Who is at risk? Who is at risk to develop a dementia? This is the question that we have to reply to all of the family members who are concerned about the outcome of the memory loss after COVID-19 infection. We should consider the comorbidities, multiple risk factors for dementia. As Dr. Ayati explained, we have similar risk factors for the people who have high mortality rate after COVID-19 infection and also Alzheimer's disease. And also the picture of COVID-19 infection in the severe forms of this infection, it has a direct relationship, significant relationship between the severity of COVID-19 infection and this consequences, especially in this context, cognitive deficits with COVID-19 severity. Next slide, please. Next slide, please. I'm not sure that if you hear me. Okay, important consideration is beclouded dementia. I think the number of the patients with beclouded dementia, the patients who the patients who have had experiences, do you hear me? Sorry. The patients who have experiences, for example, delirious state or sepsis and other issues that I mentioned, we should consider any cognitive or behavioral symptoms as the sequelae of COVID-19 dementia. Do you hear me? I'm not sure that everything is going on fine. Would you please show me the next slide? As a sum, I think, and we should conclude that we need more time to identify the nature of cognitive consequences of COVID-19 pandemic. Considering the long time of developing dementia for the neurodegenerative dementia, such as Alzheimer's disease, FTD, and DLB. And we face with a very complicated clinical picture of a very acute onset infection, not just an infection, but vasculitis maybe, or the consequences of metabolic disturbances and hypoxia on a frail and vulnerable brain, aged brain, and maybe the pre-existing dementias. If we can conclude that many of the patients that we have, maybe they could have a normal life despite of pathological Alzheimer's disease, if their cognitive reserve is sufficient to protect them. But after COVID-19, the prediction of dementia for these patients have been changed. So it seems that we should wait to have a conclusion about the future of these patients. Just we should conclude the impact of fatigue and depression. We should follow up every of these patients, every elderly patient with the history of COVID-19 infection, and have a clinical evaluation precisely in terms of cognitive deficit. And also we should consider cognitive rehabilitations before we start donepezil or other anticholinergics and also memantine. We should think to the non-pharmacological issues, aspects of our management. Thank you for your patience with the problems that I had in technical issues. And I think that there is one slide remained. Thank you. If it is possible, please.
Thank you, dear Professor Noroozian, for your informative and interesting talk. There's a question. I think at the moment, all of clinicians in Iran or other countries usually involve with their patient through the online services. And we usually see our patient by WhatsApp or Zoom or Skype. And I think it's an important issue that I think we need to consider new regulation for our patient and assessment of them. I would like to know your comments about this this kind of doctor-patient intervention or communication. And I would like to hear your experience. And secondly, did you have any patient with dementia that contracted COVID-19 infection and presented with some cognitive problems or not?
Thank you for your very important question. Actually, we have presented a manuscript to the Alzheimer Association International Conference 2021, which will be held in the future days, 26 July in Denver. And I and Dr. Mohammad presented a lecture about online televisit for patients with dementia. This is very important because of many reasons. For example, in normal situation, you know that elderly patients have troubles to go to the doctor's office, especially in metropolitan cities like Tehran. It's not easy for them and for the caregivers. So first of all, it's very convenient for the families and for the patient to stay at home in normal life, especially in this pandemic. It's very safe for them, and also for the doctors and healthcare teams. It's very convenient. But if I have time, I would be happy to present our paper in the future. I think it's important to say that we can do neuropsychological tests online. It's a little bit difficult for some of the tests. For example, the families want to help and ask the questions, and for the records that we should have, it's a little bit difficult. For evaluation of neurological heart sign, for example, we cannot test Babinski. But I'm personally interested in assessment of gait, because gait can show us the tone of the muscles, the weakness, and extrapyramidal symptoms. So it's very helpful when we have no way to have access to the patients in Khuzestan, in Sistan, Baluchistan, and it's very important to do this. I have very positive experiences. And at the end, for your second question, yes, we have many patients. We are working on the data. We have many patients with new onset cognitive symptoms after COVID-19 pandemic. And I think it's too early to decide about the nature of this. Maybe it's not a neurodegenerative dementias, or maybe an MCI who have converted to Alzheimer's disease or FTD. It's not easy to decide about the nature of these disorders. Sorry for talking.
Thank you so much for sharing your valuable experiences. Thank you. And I would like to hear from other speakers, Dr. Ayati, Dr. Vahabi, and Dr. Etesam. Is there any comments or adding issues regarding our talks today or not? Thank you.
No, I just want to say thank you so much, Dr. Noroozian. I really enjoy it. It's making me sad to see some technical issue. I wish I had much more time to listen and learn from you. And I truly appreciate about your expertise in the field. And I'm looking forward to hear your presentation actually. And I'm actually going to join in virtually there, but I'm waiting for that. And it will be big congratulations for that. And again, thank you so much for all you guys are doing for, especially about the dementia care, management, and education. I think the most important thing, which I think we need to know, is, as exactly in the last comment that we talk about it, it's true that we are still not very active in therapeutic management of dementia. But there are lots of things that we can do at this level. When we talk about prevention, I know that we have a lot of the theory about prevention, but it is very important that we expand the education in public, especially in the younger age. Unfortunately, the focus when it comes to dementia is more in geriatric, which is very late because all the risk factors already affected. We talk about all the risk factors: coronary artery disease, hypertension, diabetes for a long time, and the lifestyle that we choose. And that's definitely can later causing some of the issues. I think there's important things that we started to educating people to understanding about this disease. If there's any risk factors that they can modify, we can start to doing this education. Not very late. Again, the problematic part of our healthcare is that when the people is getting old and start to ache and start to have joint pain and high blood pressure, they're just going to start to go to see a doctor. We need to expand the healthy aging process in order to really prevent dementia. Even today, as Dr. Noroozian and again, Dr. Vahabi knows very well, if we wanted to be successful in treating dementia, there's no way that we can be successful till we find early patients population, the one that they just starting the pathological change. Unfortunately, we don't have any way to find this population. And majority of pharmaceutical trial, the reason they're failing because their population is actually in the people that already have advanced dementia. If we can find the people in that age, there is no way we can find it till we increase the education or healthcare system or physicians or primary care physician, general practitioner. When they find the sign of memory change, they don't say that, oh, this is a sign of aging. This is absolutely wrong. I think we just need to teach people that there's a difference between, and again, in the United States, I always say the people come, they have moderate stage of dementia, and they said, oh, we thought till a month ago, this is just because of aging, but this is not aging. Aging, memory loss is different with dementia. I think it's important that we expand this education to a general public to understand. As I said, COVID dementia has already been a pandemic, and it will be a massive pandemic, more than COVID. It will affect us, every single of us. and in the future. It affects the life of our children. The fact that I'm sure that you learn about the data. Majority of the resources for children in the future will spend for the money that we have to spend for elderly people which elderly people in the future will be us in the future, and they have to spend the money for us. That means resources their children is going to have for a school education, again, a hospital, and many other things that's just going to be to us. I think that's important to have this. But I think that one of the questions in the comments I heard about what can we do to improve, and I just put in a comment, is still education. Education of the people to understanding, or especially our healthcare providers right now in the hospital, when they're facing with COVID-19, when they have dementia patient, probably they need to know that they cannot treat the same method that they're doing for somebody who come with COVID and low oxygenation. We try here, at least in Stanford, we try to really focus on a more palliative care approach for people with dementia, try to do more supportive management, talks about goals of care in the earliest stage with the family. And it has been successful. I can say my experience for the last 1.5 years, it's been very, very good and successful. And I think that's probably going to be the comments at the end that I wanted to add here.
Thank you, Dr. Ayati, for your nice comment regarding education for protecting people and public health against the dementia. Regarding education, there are two adding points I want to mention here. There are lots of evidence that shows that only education and only changing the attitude do not guarantee the changes. And maybe we need some health services to detect, to prevent people who are vulnerable to dementia. And there are lots of evidence in Scandinavian countries and in NHS reports that with qualified services for memory clinics and for health services that can improve protection and early detection of dementia, plus education. And there is another issue in Iran we have got, that some misinformation makes people more concerned about dementia. And I think Dr. Noroozian had a good experience about the Alzheimer phobia. We have lots of patients and people come to our office and ask about the dementia, and they are young people. And for example, a lady who is 35 years or a man who is 40 years and come to the office, and they usually ask about the dementia. And I think pure education with any feedback only in media maybe not would be totally helpful for some societies, and we need to prepare some qualified services in health systems that could be completed these services. Thank you so much. Dr. Noroozian, Dr. Etesam, and Dr. Vahabi, I'm happy to hear your final comments in this webinar.
Can I say something?
Yes, yes, please.
Maybe it's interesting to point to one finding, my personal finding. Around 10 years ago, when I did a survey on my patients who have been visited in terms of cognitive their first complaint or the caregivers, 10 years or more than 10 years ago, the patients were referred to our memory clinic because of behavioral symptoms, not cognitive symptoms. When they have problems in to keep their hygiene, personal hygiene and self-care, in the stage of 6C of fast scale. When the family have trouble to care of the patient and the resistance to care and other behavioral symptoms and BPSD. But now, after 10 to 15 years, the pictures has been changed. It's really interesting and promising. Most of the referral patients are the people who are, as Dr. Arbabi mentioned, are the people who are concerned about cognitive symptoms, and they are in the stage of MCR or even SCI, subjective cognitive impairment, or in the stage of mild Alzheimer's disease. Just we have problem for FTD patients because of, very, very difficult point in FTD frontal variant and the overlap with psychiatric symptoms. So it's, I think, even in our country with lots of problem in mental, in the healthcare service and, for policymakers in terms of many issues that we have, I'm optimistic about this issue. I think the public knowledge have been raised during the previous years because of media.
Thank you, Dr. Noroozian. Dr. Etesam, do you have any comments regarding the issue?
Thank you, Dr. Arbabi. I will speak at the end of the session and for thanking the participants. Thank you.
Thank you so much. And Dr. Vahabi, do you have any final comments?
I only thank you from my colleagues and my professor, Dr. Noroozian, and you. And again, I thank you for Dr. Ayati to accepting our invitation to this webinar, and for Dr. Farnaz because of their effort in scientific secretary in this webinar. I learned more today, and I apologize because of my net disruptions. And thank you.
Thank you.
I'm so grateful for your contribution. I think other than my lecture, the other lecture was very informative and useful, and I hope to see you soon and have a nice and safety life during this difficult time. Thank you.
Stay safe. Thank you so much. Appreciate it.
Thank you very much, Dr. Arbabi, and I would like to thank all of the colleagues for being here. Dr. Noroozian, it was an honor. As usual, I learned a lot from your speaking. Dr. Ayati, as a colleague far from Iran, it was very kind of you participating in our webinar as a lecturer and sharing your knowledge and experiences with us. And Dr. Arbabi, thank you for your constant kindness and cooperation with us and taking over the management of this session today. And also I thank Dr. Vahabi for being here. I have been working with Dr. Vahabi and Dr. Noroozian and Dr. Arbabi for several years, and it has been an honor for me. And I hope that Dr. Ayati, we can continue this cooperation again. And also I thank our audience because of paying attention to this webinar and their patience in this process. And also I thank Ms. Alaeddini and the other colleagues in International Affairs for managing this webinar. I hope for you a good day and staying safe, and thank you. And
thank you.
Bye.
Thank you.
Bye.
Bye. Bye. Bye.